Mohamed Shakir. He will talk about prostatic artery embolization, what you need to know.
Good morning, everybody. Thank you, Professor Dr. Manal Halim, for inviting me to talk about prostatic artery embolization for PPH. What you need to know. Actually, prostatic artery embolization as intervention technique, it's one of the challenging techniques. Most of these populations are older patients with atherosclerotic changes. Besides the many arteries, many branches of the internal iliac artery with many anastomosis in this area. And the prostatic artery is one of the smallest of these branches, and it may be tortuous artery, or usually it is tortuous artery, and sometimes there is acute angle at its origin. Besides that, there is variable origin of prostatic artery from patient to another. It is not standardized or standard origin, and the origin may vary from patient to another, and even may vary from one side to the other side in the same patient, and the bilateral symmetrical origin occurs only in 50% of patients. However, with expert hands, technical success ranging between 98 to 100%. These are our inclusion criteria for PE in PPH according to Pesco et al., the man who invented this technique. PPH with moderate or severe LUTS, mainly obstructive symptoms, refractory to medical treatment for at least 6 months, with IPSS score more than 8, quality of life score more than 3, and prostatic volume more than 40 grams. On the other hand, the exclusion criteria include prostate volume less than 40 grams, prostate cancer, large bladder diverticuli, large bladder stone, impaired renal function unless the patient is on dialysis, and active UTI infection, which is relative, should be treated before BE. First of all, the most important is to know by heart the anatomy of the prostatic artery for anyone who wants to practice this technique. So how to identify the prostatic artery? Prostatic artery is one of the branches of the anterior division of the internal iliac artery, which have many other branches. Mostly the prostatic artery is the second in order, and mostly it is tortuous in course, as you see, second to the superior vesical artery, passing lateral and caudal to the superior vesical artery to give feeding to the PPH. On the other side, here, this is the superior vesical artery, and again, the second branch, the tortuous branch, is the prostatic artery. It ends by 2 branches, usually central branch for the adenoma and peripheral capsular branch, as you see here. The central branch supplying the adenoma, and the peripheral capsular branch, as well as here, central and peripheral capsular branch. According to Carnevali et al., Carnevali is the other man who invented this technique also at the same time with Pesco. Pesco from Portugal and Carnevali from Brazil, and he put this classification for the origin of the prostatic artery and classified the origin into 5 categories. Category 1, originating from the superior vesical artery. Category 2, from the main trunk of the anterior division of the internal iliac artery. Category 3, from the obturator artery. Category 4, from the internal pudendal artery. And category 5, from any other branch, even sometimes from the external iliac artery, as we will see. And most of origins of the prostatic artery are almost always in all series from the superior vesical artery type 1 and from the internal pudendal artery type 4. These together represent about 2/3 of the origins of the prostatic artery. And the same in our series published in the AGIR in 2021 on 210 patients for the anatomical variations of prostatic artery. Again, the most 2 origins were the superior vesical and the pudendal. However, in our series, the superior vesical was more, about 40%, and the internal pudendal origin about 30%. These are examples of the different origin. Type 1 arising from the superior vesical artery by common trunk on the right side, and again here on the left side, this is the superior vesical and the prostatic artery. Type 2 arising from the main trunk of the anterior division. This is next to the superior vesical artery, also here next to the superior vesical artery. Type 3 arising from the obturator artery. This is the obturator with characteristic termination, and this is the prostatic artery. Again here, the obturator artery, and this is the prostatic artery. Type 4 from the internal pudendal artery. This is the internal pudendal artery, and this is the prostatic artery. And again, here the internal pudendal artery, and this is the prostatic artery. Type 5, any other origin other than the first four classes, and here the prostatic artery arises from the external iliac artery, as you see here. There is no prostatic artery in the internal iliac, from the internal iliac artery. This is the external iliac, and this is the origin of the obturator together with the prostatic artery, and this is superselective catheterization. This is the obturator artery, and this is the prostatic artery supplying the left hemisphere of the prostate. Many anastomosis in this region between the prostatic artery and nearby arteries. The most common of those are the benign anastomosis, rectal and vesical anastomosis, and the anastomosis are very common actually, and we should be cautious to avoid any non-target embolization. So how to avoid non-target embolization? Oral technical points. We try to do superselective catheterization as distal as possible of the prostatic artery, and during embolization, the embolization is very slow to avoid any reflux of particles or the embolizing material into non-target arteries. We do different projections to clarify the origin of the prostatic artery and do selective catheterization. We can do coiling of the non-target arteries, proximal coiling of non-target arteries. It has no side effects, and it protects these non-target arteries from the embolization. Of course, we can use the cone beam CT if available. It is a plus. And we do intermittent control angiography during the embolization. So we inject some embolizing material and then do intermittent control angiography to see if there is any collaterals open to avoid non-target embolization. So how to prepare our patient for prostatic artery embolization? We do pelvic ultrasound with measurement of post-voiding residual urine, and of course measurement of the prostate volume. We do urine analysis plus or minus culture if infection is suspected clinically, or if there is pus in the urine analysis, and also semen if there is more irritating symptoms and suspected infection. Semen analysis plus or minus culture of the semen. BSA is routinely done total and free to exclude the possibility of cancer prostate, and also trust to exclude presence of any suspicious focal lesion and for accurate measurement of the prostatic volume. And if there is suspected focal lesion, we shift to multiparametric MRI, and if there is suspicious lesion, we can move to truss biopsy. And if we did truss biopsy, it is better to postpone the procedure. If there is no cancer, we postpone the prostatic artery embolization for about 2 weeks after the truss to avoid any opened channels inside the prostate from the truss biopsy. And the routine investigations before any transcatheter maneuver, CBC, renal function tests, and coagulation profile. Urine flowmetry is also done, not as routinely, of course, but if there is doubt about which is the main symptoms of the patient, whether obstructive or irritating, so we do urine flowmetry, and if Qmax is less than 15 milli per second, this patient is indicated for intervention. And of course, we measure the severity of the symptoms of the patient, every patient by IPSS score symptom. If the score is above 8, this patient is indicated for intervention, if not responding to the medical treatment. Quality of life score, if we have score 3 or more, this patient is indicated for intervention. Some tips and tricks about the technique. It is a transcatheter technique done under local anesthesia, transfemoral puncture. So we introduce our sheaths, 5 or 6 French sheaths, and then our mother catheter, 4 or 5 French mother catheter from the right side, and we do crossover starting by the left side first. And then we do superselective catheterization of the prostatic artery using microcatheter, almost always required microcatheter for catheterization of the prostatic artery. We never do this with the mother catheter. And the oblique view is very important to clarify the origin of the prostatic artery, and Carnevali et al. Suggested this acronym, which is PROVISO, to facilitate to know the branches of the internal iliac artery, the anterior division, and selected the prostatic artery. So the P is the pudendal artery, the R is the rectal artery, middle rectal artery, the O is the obturator artery, the VI is the inferior vesicle, which gives rise to the prostatic artery, or actually it is the prostatic artery itself. S is the superior vesical artery, and O for the oblique view, which is essential to clarify the origin of the prostatic artery. As you see here, this is the anteroposterior view. All branches of the internal iliac artery are overlapped, and we cannot discriminate where is the prostatic artery. And when we do 25 degrees oblique to the same side, or ipsilateral side, we can clarify this is the superior vesical artery, this is the prostatic artery. But where is the origin? Is it from here or is it from here? We do more oblique 35 degrees, so it is very clear that the origin here is from the superior vesical artery with a common trunk. So this is essential. And the oblique view varies from patient to another, usually between 30 to 50 to the ipsilateral size with 10 degrees cranial oblique. Catheterization is always by microcatheter, as we said, ranging in size between 2.2 to 2.7 French. These are the different particles used for embolization of the prostatic arteries. We have the embosphere of Merit, we have the embozine, we have the BVA of Boston Scientific, and all have similar outcome. There is no significant difference in the outcome regarding the different embolizing particles, but the size matters. The size matters. If we do by embosphere, we use a 300, 500 micron. If embozine, 400 micron. If BVA, 150 to 150 size. And these particles obtained the FDA approval in 2017 for prostatic artery embolization. Follow up the patient. The patient is charged in the same day. This is outpatient procedure, and post-embolization syndrome may occur for 1 to 2 weeks. It is very tolerable, very mild symptoms, maybe some perineal pain, some dysuria, some frequency. After the post-embolization syndrome finishes, the patient starts to practice improvement in his symptoms compared to the symptoms before prostatic artery embolization, and then the process starts to decrease in size gradually over 3 to 6 months, and eventually it decreases about 30 to 50% of the original size in the majority of patients. Significant clinical response occurs in 85 to 95% of cases in terms of improvement of the symptoms, the IBS score, quality of life score, Qmax, and the prostate volume reduction. Bilateral embolization can be achieved in up to 90% or 95% of cases, and recurrence may occur in 5 to 10% of cases after 5 years, and this mostly occur in the unilateral embolization cases. Regarding complications, BAE actually is very, very safe technique if done by expert hands. Infection may occur in 2 to 3% of patients, more in the diabetic patients, can be controlled by antibiotics. Complications due to non-target embolization, including hemospermia, bleeding per rectum, hematuria, bladder, rectal or penile ulceration, may occur in 1 to 2% only of cases, and usually it is mild and self-limiting complications. So, to summarize the advantages of prostatic artery embolization, it is done under local anesthesia with minimal pain and more suitable for older patients with comorbidities. BEE is done as an outpatient procedure without need for hospitalization, no need for routine insertion of urine catheter after, no upper limit for the prostate size to be treated by BEE, avoid non-surgical complications as retrograde ejaculation and bleeding, and it is ideal option for patients who want to preserve the sexual function, and it can be repeatable procedure. Many studies up to systematic reviews and the meta-analysis compared the prostatic artery embolization with the gold standard for PPH with TURP, and it concluded that subjective symptoms improvement was equivalent between TURP and BE, while TURP demonstrated larger improvement of some objective parameters like the Qmax and prostate volume reduction. However, BE was associated with fewer adverse events and shorter hospitalization time. And finally, welcome of BE to the guidelines. NICE introduced the BE in its guideline in 2018, and the recommendations concludes that current evidence at 2018, current evidence on the safety and efficacy of prostatic artery embolization for benign prostatic hyperplasia is adequate to support the use of this procedure, provided the standard arrangements are in place for clinical governance, consent, and it is reimbursed in England. And finally, the American Urological Association last year included the prostatic artery embolization in its guideline. This is the Journal of Urology, the official journal for the American Urology Association. And it stated that prostatic artery embolization is a distinct minimally invasive treatment option for benign prostatic hyperplasia with LUTS that has demonstrated its safety and efficacy and is now supported in the most recent EUA guidelines. Of course, collaboration between both urology and IR is critical to identify the patients who may benefit from BE. And also, they concluded that evaluation and the procedure evaluation be done by experts. IR is challenging technique, as we said, so any IR want to practice prosthetic artery embolization should have a very good experience in other embolization technique. Prosthetic artery embolization overcomes the limitations seen with other minimally invasive surgical techniques for BPH without upper limit on the gland size or the presence of a median loop. However, results are less predictable in glands under 60 cc and in patients with severe atherosclerosis. So our take-home messages: prosthetic artery embolization is technically challenging, nevertheless feasible, safe, effective treatment option for BPH patients. BEE shows comparable results to TURP in terms of symptomatic relief with fewer complications and shorter hospital stay. BEE is included in guidelines as a valid, safe, and effective treatment option for BPH. Thank you very much.
Thank you, Professor Shakir, for the very elegant presentation. And I would like to ask the floor for if they have any question on the subject. Okay, so I would like to make a small comment as a urologist. From our point of view, as urologists, our guidelines have changed over the past 2 years due to the many studies that were made on that issue, on the prostatic artery embolization. And actually 2 years ago, the prostatic artery embolization was categorized as it should not be done outside clinical trials. However, the guidelines have changed now, and now it is a valid clinical option for patients who are not willing to undergo a surgical operation. So it is now considered as one of the valid, minimally invasive interventions for benign prostatic enlargement. With still, I would like to ask you about the, from your point of view, what do you think about the prostates, or did you have any difficulty with the prostates larger than 80 grams? Because it's still considered more for the smaller sized prostates. We still don't have solid data on the large size prostates.
Okay, thank you very much, Professor Dr. Hani, for your comment. And actually, no, on the contrary, prostatic artery embolization, as the prostate volume increase, it is more beneficial. It's not beneficial in the small prostate less than 40. 40 to 60, this is gray zone, but yes, most of patients benefit. But more than 80, definitely it is valid option, and no upper limit, as mentioned in the EUA guidelines recently. No upper limit for intervention by BEE, and we performed cases actually up to 350 grams. This is advantage for the prostatic artery, actually.
I'm talking about the technical difficulty.
No, but on the contrary, it is more easy. More easy, because the prostatic artery becomes more hypertrophied with more larger volume of the adenoma, the larger the prostatic artery. So it is more easy for us to catheterize it and do the embolization.
Yes.
It is more easy.
Do you see any more
even,
branching,
sorry for
any more branching, more anastomosis with the...
We have our technical points of view to avoid the non-target anastomosis for any expert interventional radiologist. And even we advise the beginners of this technique to start with the bigger volume prostate, because it will be easier than the small volume prostate.
Thank you.
Thank you very much.
Okay.
Thank you. Thank you.
So now we proceed